war-related impact is on the mental health. So we will be taking questions at the end of the presentation, all the 4 presentations. Now I will be inviting Dr. Adivya Srivastava for the next presentation. Dr. Adivya Srivastava is a pass out from KMC Mangalore and is a psychiatrist. He is currently working at Homibhava Cancer Hospital, which is a unit of Tata Memorial Hospital, Mumbai. He has several research publications to his name, to his credit. So over to you, Dr. Adivya, for your presentation. Kindly unmute yourself.
Good evening, everyone. Am I audible?
Yes, you are audible.
So, good evening. Today, I will be discussing the wound of conscience, moral injury beyond PTSD toward DSM recognition. This title is intentional. The phrase wound of conscience reflects that the core disturbance is not simply emotional dysregulation, but a disruption of the individual's moral identity. At a broader level, this talk addresses a gap in contemporary psychiatry. While PTSD has been extensively studied and codified, moral injury remains uncodified within DSM 5, highlighting a gap between diagnostic systems and clinical reality. My aim today is not to argue for premature categorization, but to demonstrate that our current frameworks may be insufficient to fully capture war-related psychological suffering. So not all wounds of war are rooted in fear. Some arise from the violation of one's own moral code. This distinction is fundamental. PTSD asks what threatened the individual. Moral injury asks what the individual believes they have done, failed to do, or witnessed that violated their moral framework. This shift from external threat to internal moral conflict represents a different axis of psychopathology, one that psychiatry is still in the process of fully conceptualizing. The objectives of this presentation are fourfold. First, to define moral injury using established literature, particularly the work of Shea and Slits. Second, to differentiate moral injury from PTSD within a DSM informed framework. Third, to explore emerging neurobiological and cognitive perspectives while remaining cautious about over interpretation. And finally, to translate this understanding into clinical practice, including assessment, formulation, and management studies. So, why this matters now? Modern warfare has evolved significantly. We now see increased use of remote technologies such as drones, complex rules of engagement, and situations where ethical clarity is reduced. These contexts generate experiences where individuals are not necessarily fearful but morally conflicted. Clinically, this translates into presentations dominated by guilt, shame, and moral dissonance rather than hyperarousal or avoidance. PTSD has been the dominant framework in war psychiatry. It is well defined, evidence based, and clinically useful. It focuses on threat processing, fear conditioning, and safety learning. However, its strength is also its limitation. It is primarily a fear-based model. This means that forms of suffering that are not rooted in fear may be under-recognized or misclassified. In clinical settings, many patients do not primarily describe fear. Instead, they describe guilt, shame, anger at themselves, or a sense of having violated deeply held values. These experiences do not align neatly with DSM-5 PTSD criteria. This creates a conceptual gap, one that moral injury attempts to address. So, moral injury refers to psychological distress resulting from actions or lack of them which violate one's moral or ethical code. This includes acts of commission, acts of omission, and perceived betrayal by authority. The key element here is not the objective event, but the subjective moral appraisal of that event. This makes moral injury fundamentally different from traditional trauma constructs. Jonathan Shea introduced the concept through his work with Vietnam veterans. He emphasized betrayal by authority in high stakes situations. This model highlights the importance of trust, leadership, and institutional context. Patients often describe not just personal guilt, but a profound sense of betrayal by systems they relied upon. Litz and colleagues expanded the concept. They proposed that moral injury can arise from perpetrating, witnessing, or failing to prevent acts that transgress moral beliefs. This model introduces the idea of cognitive dissonance and moral disintegration. It is particularly useful in understanding individual level processes. Let me draw your attention to two key distinctions here. Shea emphasizes betrayal by authority, which is an external focus. And Litz, on the other hand, emphasizes internal moral transgression and internal focus. In reality, these often coexist. A patient may feel both betrayed by authority and guilty for their own actions. Recognizing both dimensions is important for comprehensive formulations. Clinically, moral injury is categorized by guilt, shame, anger, loss of meaning, and social withdrawal. These are not peripheral features, these are central. Patients often describe persistent moral rumination and difficulty reconciling their actions with their identity. This leads to profound psychological distress. It is important to distinguish guilt and shame. Guilt relates to specific actions, like I did something wrong. Shame, on the other hand, relates to identity. I am wrong. So there is a difference between I did something wrong and I am wrong. In moral injury, shame is often more pervasive and damaging as it affects the individual's sense of self. Moral injury often leads to existential distress. Patients may question their identity, purpose, and values. They may experience loss of meaning, spiritual distress, and values. They may experience loss of meaning, spiritual distress, and alienation. This goes beyond traditional symptom-based models and enters the domain of existential psychiatry. So PTSD versus moral injury, this remains uncodified within DSM-5, highlighting a gap between diagnostic systems and clinical reality. PTSD is a formal diagnosis with defined criteria. Moral injury is not a diagnosis, but a construct that emerges from clinical observation and research. This distinction is important when considering classification and treatment. So core effect in PTSD is fear, and in case of moral injury, it will be guilt or shame. The cognition in PTSD will be on the grounds of I am unsafe. In terms of moral injury, it will be I am morally wrong. Focus in PTSD will be on safety, and in case of moral injury will be on self-repair and the meaning of self. Let me draw your attention to two key distinctions here. PTSD involves hyperarousal, avoidance, and fear-based intrusions. Moral injury involves moral rumination, self-condemnation, and withdrawal driven by shame. These differences have direct implications for clinical management. In case of PTSD, the patient avoids the triggers. In case of moral injury, he gets socially withdrawn. And the effect, as I already discussed in PTSD, will be around fear and anxiety. And in case of moral injury, it will be guilt or shame. Although both involve guilt, the nature of guilt differs. In depression, guilt is often generalized and pervasive. In moral injury, guilt is specific and tied to a moral event. This distinction helps guide treatment decisions. In case of depression, it will be pharmacotherapy, and in case of moral injury, it will be by narrative repair, which will be discussed later. Moral injury is not a DSM diagnosis, therefore, clinical formulation becomes essential. This involves understanding context, moral beliefs, perceived responsibility, and meaning. A purely categorical approach is insufficient. Emerging research suggests involvement of network related to moral cognition, emotional processing, and self-referential thinking. However, evidence is still evolving. We must be careful not to overstate neurobiological findings. At present, these insights are best viewed as supportive rather than definitive. The ventromedial prefrontal cortex plays a key role in moral reasoning and value-based decision-making. Alterations in this region may contribute to persistent moral conflict and maladaptive appraisal. This aligns with the cognitive aspect of moral injury. The limbic system, particularly the amygdala and insula, processes emotional salience. In moral injury, guilt and shame may become highly salient and persistent. This contributes to emotional distress and rumination. The default mode network is involved in self-referential thinking. In moral injury, increased activity may contribute to persistent self-evaluation and rumination. This may explain why patients cannot let go of moral events. Modern warfare introduces unique ethical challenges. Remote operations, drone warfare, and ambiguous rules of engagement create situations where moral clarity is reduced. This increases the likelihood of moral conflict. Consider a 32-year-old drone operator. He reports no fear-based symptoms, but experiences persistent guilt after a strike causing unintended civilian casualties. This immediately raises the question of moral injury. Like, he's a drone operator and he must have been given instructions by the authorities to strike the opposite side. But by mistake, if he strikes a hospital or a school facility, then that results in a moral injury. He will be suffering from moral injury and will be having guilt and shame. So by the help of this case presentation, it will be easy for you to understand what is moral injury. The patient reports self-condemnation, withdrawal, and moral rumination. Importantly, there is no hyperarousal or avoidance. This suggests a primary process different from PTSD. Assessment requires a direct inquiry into the moral beliefs and perceived wrongdoing. We must ask directly, like we can ask leading questions in such cases like, what violated your values? Without this, moral injury may be missed. So assessment differences, PTSD assessment focuses on threat, moral injury assessment focuses on moral appraisal. This requires a shift in clinical questioning and perspective. In case of PTSD, we can ask what frightened you. In case of moral injury, the questions will be on the lines of what violated your values. Focus will be on threat, and in case of moral injury, it will be moral appraisal. So moral injury is associated with depression, suicidality, and substance use. Some studies suggest it may be more strongly linked to suicidal ideation than PTSD. This highlights its clinical significance. I repeat, some studies suggest that it may be more strongly linked to suicidal ideation than PTSD. Clinical common errors include labeling all distress as PTSD and ignoring moral conflict. These errors lead to incomplete treatment. Recognizing moral injury improves clinical accuracy. Management focuses on meaning reconstruction, addressing guilt, and restoring identity. This goes beyond symptom reduction. It involves working at the level of meaning and values. So the treatment comparison, PTSD treatment focuses on fear extinction. Moral injury treatment focuses on meaning repair. This difference is critical in selecting interventions. In case of PTSD, we might aim at trauma-focused CBT or EMDR. In case of moral injury, the therapy will be adaptive disclosure. In case of PTSD, the goal is to reduce fear. And in case of moral injury, on the other hand, it will be to restore someone's moral identity. Effective management involves validating moral pain, exploring values, and contextualizing actions. Avoid reducing moral distress to symptom checklists. Engage with the patient's narrative. Adaptive disclosure therapy integrates exposure with meaning making. It specifically addresses guilt and moral conflict. This makes it particularly relevant for moral injury. Narrative approaches help patients reframe experiences and restore coherence. They allow integration of the moral event into a broader life narrative. Compassion-focused therapy this approach targets shame and self-criticism. They help patients develop a more balanced self-view. This is particularly useful in shame-dominant presentations. Moral injury raises important ethical questions. We must consider individual responsibility in the context of systemic constraints. This requires nuanced understanding. Psychiatry may need to expand its framework to incorporate moral dimensions. This does not necessarily mean immediate DSM inclusion, but recognition of conceptual gaps. There is a need for standardized measures, longitudinal studies, and treatment trials. Current evidence is promising but incomplete. Recent literature suggests a spectrum including moral distress, moral trauma, and moral inquiry. This may help refine future classifications. So PTSD does not capture the full spectrum of war-related suffering. Moral injury represents a distinct but overlapping construct. Both must be considered in clinical practice. So if PTSD is the disorder of fear, moral injury is the wound of conscience. Recognizing this distinction allows for more accurate understanding and better patient care. Thank you.